The 11th season of Consider This is brought to you in part by From the Top, a national program showcasing the musical talents of young people. From the Top can be heard on KVNO Classical 90.7 each Saturday at 6 p.m. Consider This, a program of issues and information behind today's news. Once again, from the campus of the University of Nebraska at Omaha, here is your host, Kathy Wyatt.
Imagine driving across the state in your car. You're alone and you crash. The accident is a serious one. You're taken to the nearest emergency room where no one knows who you are or has access to your medical files, including any medications you may be taking. So now what? Hi everyone, I'm Kathy Wyatt. Welcome to this week's edition of Consider This. Our topic, electronic health records, an initiative designed to help save your life, especially in circumstances like the one I just described. Here to talk more about this today are Dr. Harris Frankel, a neurologist, a member of the statewide Nebraska Health Information Initiative, and member of the Nebraska Medical Association. Dr. John Jacobson, a general practitioner at the Fillmore County Medical Center, and Sharon Welna, who is Associate Director for Compliance and Planning at UNMC. Welcome to all of you, and thank you so much for joining us.
Thank you.
Dr. Frankel, we'll start with you. Just what is electronic health records?
Well, the term electronic health record has actually received considerable attention and debate as to the terminology, but in its simplest terms, in my hand here I have a traditional paper medical record. It's the patient's file with all of their health information, including insurance information, demographic information. And what the electronic health record is this same record only in digital or electronic format.
Okay, and we have a graphic here for the next question, which is what types of electronic health records are there?
Well, really the patient's medical record, as you know yourself, is made up of a variety of different pieces of information. The electronic health record is a compilation of the patient's different records, maybe x-ray data, laboratory data, personal health information, clinic encounters, hospital encounters, and all that data in electronic format that makes up the individual electronic medical record. And when all that information is compiled into a central vault, if you will, or a central view when being looked upon by providers, that makes up the electronic health record.
Okay, and we have different types. There's the consumer, right?
Correct.
And then there's the health management and then physician. Can you talk a little bit about each of those?
Yeah, I suppose in it, to break it down even more simply, we think of this in two different spokes. One, the provider or health management side of things, which is controlled by the institutions and or the providers providing the care who generate those records. And then the patient's or the personal health record, which is that component of the medical record where the information is controlled and managed and updated by the patient.
Okay, and I understand that underneath the consumer we have Google operates and Blue Cross Blue Shield. What are we looking for there?
Well, there are a variety of commercial products by companies that you've named. Blue Cross Blue Shield's a payer. Google, everybody knows about Google. Microsoft is getting into this where they're providing consumer portals or the ability for the consumers to aggregate their health information into a single vault, if you will. They become the custodians of those records. It's their responsibility to request that their information be loaded into their personal health record. They then have the responsibility of maintaining that health record and updating their personal health information as to the degree they can. For instance, updating their medication list, allergies, etc. It then becomes incumbent upon the patient or the consumer to bring with them the ability to access those records at a patient-physician encounter or in some other format by which the physician or other providers can access their health information.
Are people utilizing that?
Some are. I'm not convinced that they've taken off as robustly as it might have been predicted, but some individuals are using those vehicles.
And the advantages seem pretty obvious, but
the advantages up front do seem obvious, but the disadvantage is that it really adds another step into the process of health information exchange. In my opinion, the ideal situation would be for institution to exchange with institution or provider to exchange with institution or vice versa and take the patient out of the middle and being responsible for transporting that information. Without question, however, the access to that information really has to be granted by the patient, which we'll address later as we talk about security and privacy issues.
Great. For now, tell us about this initiative that is underway across the state.
The Nebraska Health Information Initiative is a project that has really been underway for about 3 years. It's a collaborative of private and public stakeholders, and the purpose of this is to be a secure exchange for protected health information, so that, as you described in your opening comments, if an individual is at a location receiving health care that may be away from their home or even at a different site within their own community, that information on that patient can be aggregated and accessed at point of care to improve the efficiency, safety, and quality of that visit.
Okay, and what is going on now in our state and the nation to drive the electronic health records, specifically in the area of interoperability?
Well, you raise a very good question. One of the major hurdles that has been faced in this whole movement for electronic health records is the issue of interoperability. And what that is we know there are many different types of systems that can generate and store electronic information. The difficulty heretofore has been System A doesn't talk with System B. And so interoperability really relates to the ability to exchange information between disparate or different information systems. In the state of Nebraska, one of the projects that has been in play for quite some time is the Nebraska Telehealth Network. It connects the 88 critical access hospitals in the state, the public labs, and other institutions, so that mostly to the benefit of rural Nebraska, healthcare encounters, discussions, educational pieces can be conveyed in, if you will, a virtual network. The piece of interoperability is really being driven at the federal level by the development of common standards, both on part of the vendors who develop these software products and also the companies that develop the hardware, if you would, that allow these software products to run.
Okay, and Dr. Jacobson, you're actually utilizing this where you are in Fillmore County. Talk about your experiences with it.
We've actually started about 1.5 years ago loading data into our system. And what I'm talking about there is what's called a preload, where you have to take the information out of this chart that Dr. Harris is holding and load it into the system, because the system only will give you back the information that you put into it. So you have to load the past medical history, you have to load their allergies, you have to load their family history, surgical history, all of those things in. And that's quite an onus task when you start thinking that you've got 3,000 charts, 5,000 charts, 10,000 charts in your clinic, depending on the number of providers you have. So that's one of the initial drawbacks, is not only are you doing that, but your office staff is trying to run the clinic. So you're doubling up on the workload initially to get those things in. Once you get them in, though, then it's just a matter of maintaining the system. And that's really where we're at this point, which some of the things that Dr. Frankel talked about as far as interoperability, the exchanging of material or information is a big problem at this point for us. If I send a patient to see Dr. Frankel, he sees the patient, he now has to either send me a letter, fax me a letter, or communicate with me some way, give me a phone call. Well, somebody has to take that information and load that into the EMR or into the health record. So even though it's electronic and it's paperless, there still is a lot of backwards or backroom work that has to be done to keep that record up to date.
Okay, and how many, you were talking about rural, what percentage, I guess, of folks in the state are actually utilizing this at this time?
In our area, in southeast Nebraska, we're seeing maybe 50% of rural health clinics or family medicine clinics. We're also seeing some of the smaller hospitals, the critical access hospitals, are updating and going now to an electronic medical record or electronic health record. Again, another problem is, in our hospital's example of this, they purchased a different product than we purchased. So we have interoperability problems just amongst ourselves. We have you go out and you have the company will write an interface to exchange data, but at all costs. So every little step of the process is just somebody wants a piece of the pie and wants a little money. So that's really my biggest issue right now, is trying to get me to where I can talk to the University of Nebraska Medical Center, or I can talk to Bryan Hospital, or I can talk to St. Elizabeth Hospital, so that that information comes across.
So how are we going to solve that then, with so many people wanting to become involved in this, or you wanting so many people to become involved in this? What's a glitch like that going to do to get people to?
If I could, let me just add to the comments that Dr. Jacobson made. Statewide utilization or adoption of EHRs in physician offices approaches about 12 to 15%. So it's relatively low, and those numbers parallel the national averages as well. There are pockets of concentration where the adoption rate is higher, but overall in the state it's about 12 to 15%. A very good point is made, is that up until recently, the institutions themselves, the hospitals who have developed an information platform or instituted information systems, oftentimes didn't consider the outside providers who may not have been part of their primary care staffs who they might have otherwise employed, and for whom they put electronic systems into the offices as part of being an employed physician. Obviously, not all physicians are employed by the hospitals they serve. And so there is this disparate information silage, if you will, that occurs and does create significant problems, as Dr. Jacobson has described. To assist hospitals and to assist physicians primarily, to put in like systems now that will communicate with one another. There has been some relief in the Stark regulations, which are the legislative regulations that permit or prevent hospitals doing certain things for physicians so as not to give the appearance of what's called endearment or favoritism in services like this. Those regulations have been relieved such that now hospitals can provide up to 80% of the software cost to staff physicians to help them and to incent adoption of information systems in the office. Obviously, if you have providers that provide hospital care at a single institution, it becomes much easier. For physicians like myself who cover multiple hospitals in the metropolitan area, it would be difficult to simply go with a single system that was analogous to one of the institution systems, recognizing that would create interoperability and communication issues for the other health systems we cover. That being said, there is some relief available for physicians now through the help of the hospitals who have the deeper pockets, with the understanding that a lot of the hurdles to adoption have been the financial aspects of doing this, especially in private practice.
And getting help there. Now, Sharon, one of the things that I was thinking about as I was putting all of this together was the whole privacy thing. With so many people logging on and inputting information and having to access that information, let's back up just a minute and tell us what HIPAA is, and then we'll go into the rest of it.
Well, HIPAA is the Health Insurance Portability and Accountability Act, and it was passed in '96, and it's taken a significantly long period of time to get implemented. But what you have to remember is that HIPAA was written originally to govern how private practice and healthcare providers billed, and encouraging the healthcare system to move to a standardized electronic billing system, which was going to save the country a significant amount of money. Then as part of that, they implemented privacy and information security regulations. However, those regulations only apply to the organizations that actually bill for services. So like the Googles of the world right now, which do not bill for electronic services, are not governed by HIPAA, although there's legislation currently going through the Congress that would change that. From a healthcare provider perspective, there are very strict rules regarding privacy and information security, and every healthcare organization has worked very hard to implement those. The other piece that you have is with the electronic records, you have a significantly improved ability to audit, because everything that happens is electronically recorded. So in the paper record, you can't tell me who looked at that particular chart. In the electronic record, I can tell who looked at the chart. So, just as you move from the paper world to the electronic world, it's a cultural shift in what you're able to do. So I think the legislation is there to ensure that only those with a need to know the information legitimately should access it. And the penalties are there. However, just as in the paper record, you are going to have people who misuse the system, and you have to have the ability to find them and then to discipline them.
Okay, so you're not overly concerned based on kind of the progress we've made and where we've come with all of this?
Right now, the biggest risk we have is identity theft, because they're really looking at that. As far as people looking at health information in order to harm someone, I don't read very many of those things.
How is the training for something like this different? What types of things are we looking at here? We know there's some time involved, obviously, but what types of things are we looking at from a training standpoint for folks that'll be utilizing this?
I think the thing that you have to remember is that in a paper world, our culture is very adjusted to what's right and wrong when you look at paper. You would not go into someone's office and open their file cabinet and pull out a record and look at it. But when you're in your private office, people don't relate that same cultural sense of this is not the right or the wrong thing to do. So right now, I think what we're really focusing on is helping people realize that what was right and wrong in the paper world is right and wrong in the electronic world. And you need to carry those same things forward.
Well, and so far the benefits seem to be outweighing the negatives here, but I have one more question, that if I'm the one in the ER in Scotts Bluff and the system crashes, what's plan B then?
Disaster recovery is a huge component of every information system. And so you have to be able to go manual or to have other pieces in place. Just like every family should have an emergency plan, the system will have an emergency plan to ensure that the data is available.
Okay, and speaking of emergencies, Dr. Frankel, Katrina was a big one, obviously. What did we learn overall from that experience?
Well, I think there are really two things. And the obvious thing that comes to mind for most people is that paper records that were lost were unrecoverable and could not be duplicated. That's the biggest thing that I think people talk about. But probably as important in my mind, if not more important, was the inability to effectively communicate amongst different agencies before, during, and after, which speaks to the interoperability piece. And so I think those are the two major lessons that we've learned from that.
Okay. What is the next step in all of this? Where are we going? What can folks who are watching expect? Obviously, we're tapped into this in some areas, but not in all areas. What's your forecast, if you will, for this big picture?
Well, I think like many other industries, financial industry, retail, the move to create information technology as a standard in healthcare is here. There's a lot of momentum. I think people who have had the experience of using electronic health records see the benefit. And the benefit to the physician is the ability to deliver, I believe, higher quality, more cost-effective, and safer care for the patient. The benefit to the patient is that they now have a means by which they can literally maintain, or a record can be maintained for them, all of the important protected health information that is really necessary to make their visit with the physician or the hospital much more productive. There are discussions that have abounded about the potential savings that electronic health records may provide, be it in the elimination of duplicative testing, the safety piece relative to medication errors, medication reconciliation, things of that nature. And so I think the stars are really aligning for this movement to continue and to become standard practice. As has been pointed out, the biggest hurdle that we face are the privacy concerns by patients and other consumers. I think, like has been handled in the financial world, healthcare transactions through an electronic means will become standard. People will be accepting of them. And like all other relationships, most patients, I believe, trust the physicians. And if the physician implies and discusses with the patient that this really is the right thing to do for them, I believe they will be on board, and the hurdles that we perceive now and recognize that are there will become an issue of the past.
Now, Dr. Jacobson is somebody who is, using this now and listening to this, pretty on target?
Pretty much. Our patients are now getting used to walking into a room and seeing a computer screen instead of a paper chart. And the thing that's nice is you can bring up their information, say they had their fasting labs done last week. And with a click of a button, you can graph their cholesterol, what it's been for the last, for us, year and a half or 2 years, but 10 years down the road, you'll be able to show that. This is what the changes you've made in your lifestyle, the medication change, whatever. So that's one thing they really like, is to be able to see that. And I think Dr. Harris will agree, as a physician, all we are teachers. We're educators. We have to try to help our patients learn new ways and to move forward with their health. And it just gives you one more tool. The other thing that really is beneficial is educational material that's within the systems. You can go onto the internet if you have a website, or a lot of our particular system has different educational material right in it. So if a mother brings her child in and they have an ear infection, I can print out, this is what to expect. The antibiotic, this is how they should act. If these things happen, you need to call back, or you need to bring the child back to see us. Getting back to where I think this future is kind of headed, I really think that we're going to have to see a consolidation of the industry more. Simply because there are too many companies out there selling health systems or medical health records, that the interoperability issue is not going to get better or go away. I perceive, and I don't know if Dr. Frankel agrees with this, but 5 years we may have 5 to 10 major players in the market, which then will allow them to spend the money and the resources to develop the programs to get the interoperability up and to speed to where we can exchange that information.
So you're looking at about 5 years, and Sharon, you're nodding. Do you have anything you want to add to that?
The thing that I think will help, and I know that we have many faculty from UNMC who are actively involved in the standards-based communities. And the other thing that happens as we move more forward with the standards base is it's going to help us with research. Because if we can get all the systems talking about the same illness in the same exact manner, then you can do bigger correlation studies, and that will help the research community find cures faster. Because right now, if it's a very rare disease, to get all the data correlated so that you can figure out what the pattern might be takes a difficult time, because it's not all using the same nomenclature.
Dr. Jacobson?
In kind of in correlation with that too, in our particular clinic, we have physicians who've been out of medical school and residency 5 years. We've had physicians who've been out 25 years. So the standard of care issues, or the consistency of care on a particular disease process, may be treated differently by the person who's been out 25 years than by the person who's been out 5 years. The particular system we have, and they're all getting this built into them, is when you see that patient and you click their diagnosis that they have this particular COPD, diabetes, for example, they need to have a hemoglobin A1C every 3 months, they need to have their cholesterol checked every year, they need a blood pressure at every visit, they need an annual eye exam, an annual foot exam. With a click of a button, as soon as you put that in, a screen pops up and says, your patient needs this, this, and this. So the big advantage, I think, for the patient themselves is that they're going to get a consistent care with the most up-to-date standard, which is out on the market, whether that comes from the medical community with input from the insurance community or whatever. But that, to me, is a very big plus, especially in my practice in a small town, Nebraska, where we don't have, a lot of our patients don't have insurance, so we're able to do that for them.
Well, as you talk, another question is coming to mind. When you make us realize, there are some folks who've been out a few years and some who've been out a lot of years, the whole computer thing, not only for the patient who's coming in who's 78, 79, and not to stereotype, but that wasn't the computer age for them. How did they deal with that? And then the physicians who've not really been up to speed on that, how are they adjusting.
One of the issues we had, which we didn't even think about, we had 2 of our nurses who never had turned on a computer. And we expected them to start inputting data. So we had to have a crash course on this is a computer, this is how it works, this is how you input data. And they've done remarkably well with it. But the learning curve, anytime you implement one of these systems, is straight up. And depending on how computer savvy you are, depends on how long the curve is straight up. For some people that are computer savvy, they pick it up and they're off and running to the next step. But for others, it's a real stress.
Dr. Frankel?
I would say too, it's very interesting. A lot of patients believe that their information is already electronic because the rest of their world is electronic. And so a lot of people assume, well, you have this, don't you? Or you can get this, can't you? And the answer is, a lot of times we can't. And so the beliefs on the public side aren't always in concert with what reality is. But as the comments have been made, in relative to the certification and standards aspect of things, that's really what I believe the federal government's role will be in this, in developing standards, allowing private industry to develop the bells and whistles of the products. But quite frankly, it's only going to be those vendors who have the capital to invest and make the necessary changes that will be around long term.
Wonderful. Thank you all. Now, briefly, we do have a couple of websites that we want to put up for folks. One that's specific to physicians and one that's specific to the consumer. And those are there up on the screen for people to take a look at. And again, if you're watching as one or the other, go ahead and take the time to jot those down. In the meantime, I want to thank all 3 of you for joining us today. This was a very interesting discussion. I appreciate it very much, and I'm sure the folks at home do as well. So in closing, electronic health records, just another example of how sophisticated technology really has become. Pretty amazing. Thanks to our guests again for joining us. Thanks to you for watching. See you next week.
Consider This is an issues and information program produced by UNO Television. More information and program archives can be found at unotv.unomaha.edu. If you'd like to share your comments about this show, call UNO TV at 402-554-2516 during regular business hours. The 11th season of Consider This is brought to you in part by From the Top, a national program showcasing the musical talents of young people. From the Top can be heard on KVNO Classical 90.7 each Saturday at 6 p.m.